Hi Ninja Nerds! In this video today, we're going to be talking about renal calculi. So if you do like this video, please go ahead, give it a thumbs up, comment down below, and don't forget to subscribe. Check out ninjanerd.org. That's where all of our notes and illustrations for these lectures are available for you guys. So let's get started here with renal calculi, also known as kidney stones. So we're going to jump right into the pathophysiology. As we move through our renal series here, we've been talking about the kidney, the ureter, the bladder, right? And as we are talking about kidney stones today, we're going to particularly talk about why do they form. So with kidney stones, the easiest way for you to think about it is that with urine, right, our kidneys are trying to filter, make a filtrate that eventually becomes urine that we urinate out. And it's trying to create that balance of filtering out the things that we don't need and keeping in what we do need, etc. So within our urine, there's a certain amount of concentration of these things. Now, when we eat foods, when we sweat, we work out, when we take certain medications, we have any type of comorbidities or imbalances within our body, those balances of all those different electrolytes and nutrients and fluids are going to change. And when they change, they can also alter that concentration. And when that concentration is too rich, that's when we can have crystals form. Now, those crystals could be many different things, and we'll talk about them in a minute of some of the more predominant types of stones that we can eventually get. But those crystals can then eventually accumulate together and form a stone. So when we think about this, we want to look at the problems that could be occurring if we were to develop a stone, right? We have a stone up in here, we have a stone here, there can even be one predominantly right here within the opening into the bladder. And the stones, for some people, are located in the kidney. They can have no problems with them. It's when the kidney starts to move, it's when the patient starts to experience the pain and the difficulty, and then some further along the line problems. So as this kidney stone starts to move, think about it as like a really jagged stone, right? And it's trying to push through this tube. And it's a tight fit, right? Depending on the size of the stone, if it's a really, really tight fit, it's going to start creating some tears or damage along. And as it does that, the patient starts to experience pain, right? You can also experience some bleeding then within our urine. We can also have a problem where it physically gets stuck. It's not advancing anymore. It's not progressing down through into the bladder, so we can urinate it out. And then we're going to start to have that backflow, that buildup into the kidney. And why does this occur? What are some of the causes or risk factors that's going to have this patient have a problem where they, one, are developing kidney stones, and then two, potentially having an issue to pass that kidney stone? We talked about concentration, right? So one of those things could just simply be dehydration. We're not drinking enough fluid, we're not drinking enough water, okay? And we're maybe dehydrated, maybe we're sweating a lot, maybe we're on a new type of diuretic and we're urinating a lot. So because of that, our concentration is changed. There could be alterations within medications that we're taking. Because of those medications, they are throwing off all of our levels. There could be issues with absorption. So a patient that has some type of irritable bowel disease, like Crohn's or ulcerative colitis, they're having an issue with absorbing. So that is going to lead to an increase in our concentration. We can also think of them having just other chronic issues with their balances, right? They could have hypercalcemia, they could have issues with their thyroid, their hyperparathyroidism, and all of those could also cause issues with that concentration. There's a couple others that we could talk about also, where we have gout, we have issues with a neurogenic bladder or frequent UTIs that are also going to be causing a concentration with those. And it could also be a risk factor that the stone is just too big, or they've had ones previously, so it's hereditary within their family genes, and also males have a higher risk for stones. So when we talk about all these different risk factors and these causes, we're going to talk about quickly the types of stones. So there's many different types of stones that the patients can have. And for the NCLEX, it's not necessarily important to know the different types of stones, but I do want you just to understand there's different ones because that could also indicate the different type of treatment or care that we give our patients. So we're going to quickly run through the different types that we see up here. There is calcium oxalate, which is the most common. What that is there's basically an increase in calcium or oxalate within this patient, especially in their urine, that it's going to be a higher concentration, and it can be due to a lot of different things. hyperparathyroidism, hypercalcemia, hypercalciuremia, dehydration, or IBD like Crohn's. And I want you to understand that this is the most common one. So when we look at this, there's different ways that we can possibly help this patient out, changing the amount of calcium that they're intaking, changing medications, oxalate as well. And it's just a really high predominance of these. And then as we move through these stones, another one we have is uric acid. Uric acid increased in the urine, it's increased in the bladder, it's building up, right? It's going to create these crystals, create these stones. Those have to do with gout and, again, dehydration in here. So those patients, we could be treating their gout. We help treat their gout. They're going to have a better outcome of a decreased occurrence of this uric acid stone. Then we also have a struvite stone. This is more alkalinic in the environment. It's related to bacteria. So think of patients that have chronic UTIs, neurogenic bladder, where they're not able to empty their bladder as often. They're going to have a buildup of this bacteria, creating an environment that's very alkalinic, very basic, and because of that, these stones are more apparent to occur. We also have the calcium phosphate, different than our calcium oxalate. These are in alkalinic urine as well. You're going to see hyperparathyroidism and then tubular acidosis. Those are less common, very more so on the rare side, but the most rare is the cystine stone. This is an increase in cystine, causing those crystals to form into stones, and this is more on the hereditary scale. But when we look at all these stones, those biggest complications that we're looking to help with these patients are, is it progressing through the ureters down to the bladder so they can pass it? And what are their symptoms that they're having so we can treat those symptoms? Because despite all the different types of stones, and there's even more that we can categorize into, their symptoms and the clinical manifestations of the patients are relatively going to be the same or very similar. So first, there could be a patient that has these stones. It's not trying to advance anywhere through the kidney, through the ureter into the bladder, so they're not going to have any symptoms. When that kidney does decide, or when the stone does decide to start moving, that's when we could have all of these symptoms. So the biggest thing we're going to see here when we take the NCLEX, and the biggest sign is going to be that flank pain, particularly if their stone is dropping on the right side, they're going to have right-sided flank pain, or versus the left. If it's on the left-sided flank pain. So the biggest thing is going to be flank pain. So you have to remember that when we're talking to patients, they may not think it's their flank. They may say, you know, for a day or so I've been having like this, I don't know, like discomfort. I thought I threw my back out a little bit, but now it's not getting any better. It's getting worse. It almost feels like I'm getting stabbed back there, you know, and then you're going to assess your patient and you could do a light tap on both sides and they're going to really jolt because that's really painful and tender back there. So flank pain is the biggest one. It's severe, it's stabbing. They could also have abdominal distension or abdominal discomfort, right, as that pain maybe possibly radiates around to the front. That'd be causing the pain for the patient. They're going to have other signs that we're going to be thinking of, okay, is this patient having an issue with their kidney or a kidney stone? They're going to have nausea, they're going to have vomiting, okay? They're going to maybe appear to be diaphoretic, sweating, possibly having a fever. Then because of this, you want to think about that stone, right? It's trying to progress through. If they start developing a fever and that stone is possibly lodged, there could be an influx of some type of infection going on. So with that fever, we could be thinking, okay, there's backup into the kidney. This patient could have things like elevated heart rate due to the pain or potentially an infection. They could have an issue with their blood pressure, either elevated because of the pain, or if they're further along and possibly this is going on a little longer and they're starting to go on the side of septic, their pressure could be starting to drop. So you're going to start thinking about what their vital signs are looking like. This patient could also have issues with urinating, right? This stone is partially obscuring or obstructing that flow of urine. So are they having possible difficulty going to the bathroom? Are they having a decrease of the amount? So they're having urgency and frequency, but they're having less output. So all of those things, we're going to think, okay, something's going on with the kidney. And then the patient might also complain, yeah, my urine, it looks a little bloody. It looks like there's something in it. I can't really tell, but it looks like it's getting maybe a little darker, a little red, and that's where you're going to think, is that blood in the urine? Because remember, as that stone progresses, it can scrape down the sides and then cause a little breakage of the vessels, causing some blood to be apparent in the urine. So when we look at this patient, the biggest things we want to always remember, especially when we're taking an exam, is that we're going to have that flank pain. is going to be something we look for. The hematuria is going to be something we look for. And remember, it's going to be very severe flank pain. It's going to be pain that's it's very apparent, it's stabbing. It's not giving up for this patient at all. So we have a patient that comes in and looks like this. We want to make sure that we are diagnosing them correctly. So how do we do that? When we want to diagnose this patient, there's very little things that we're going to do in order to know that this patient has a kidney stone. We can do a bunch of blood work that's going to be very nondescript for this patient. But the things we can do is a urinary analysis and then get imaging. So with urinary analysis, we want to start thinking about, is there blood in the urine? Is there white blood cells in the urine? Then we're going to get an image. Why do we get an image? A couple different reasons. Can we verify that there's a stone? Great. We're going to find out where the stone is. Is it somewhere lodged at the top of the ureter? Is it down at the junction at the bottom? Is it somewhere along the middle? And then what is the size of this stone? So we can get a couple different imaging. We can get an x-ray, which we can get a kidney, ureter, bladder, which is called the KUB x-ray, which is going to allow us to visualize, again, where the stone is. We can also get a CAT scan that's going to help us notify where, if there's a stone, where is the stone, and what is the size of it. And the patient can also get an ultrasound. And the reason it's really important for us to understand where it is and also the size of it particularly is because there is a certain threshold where patients typically pass stones, and then there's a threshold where they're not going to pass the stone and where we have to do something more invasive to get the stone out. So roughly around the 4 to 6, depends on the patient, depends on the size of the patient, is where we can think about, is the stone going to pass or not? So the 4 to 6 millimeter, depending on the facility you work at, they may just say 5 is where, if it's less than 4 or around the 4 mark, the patient may pass it. If it's 4 or greater, 6 or greater, they may not pass it. So depending on the stone size, we can then talk about procedures quickly. There's many different procedures, but the NCLEX really hits on these two. So we have the ESWL, which is our extracorporeal shockwave lithotripsy. The easiest way to remember this is the shock wave is usually a sound or a laser wave that just goes in and busts the stone up into little pieces. So if you think about this, we just took one big stone, we busted it into little stones. So the patient's going to have very similar recovery to somebody who we're just allowing the stone to pass. But they're going to have the presence of a lot more littler stones, and they may have a little more blood within the urine for that first 24 hours. And that's just because we went and busted it up, so there's going to be a little more damage to the area, just a little more trauma. So it's not uncommon for patients to have a little bit of more bruising and a little bit of blood within the urine. The more invasive, if the stone is too big or it's something that we can't really bust up with the waves, we're going to go percutaneous nephrolithotomy, meaning we're going to put a small incision, we're going to go in and grab out that stone, okay? And because of that, this patient is going to potentially have a nephrotomy tube where they're going to have some drainage, okay? Very common, again, for there to be a red urine, blood looking like in that for the first 24 hours, should be progressively getting clearer, not darker. So granted, the patient doesn't go down this route. It's a very small route for patients that have to get the nephrolithotomy. Our nursing interventions are mostly going to focus on the patients that we're going to be taking care of that are going to be passing their stone without getting some type of procedure. When we're hoping that our patient can pass this stone on their own, the biggest things we want to think about is, it was dehydration, right? Dehydration was one of the biggest things, a high concentration of all these little crystals causing stones. So potentially alteration in that concentration or a patient being dehydrated. So what do we want to do? We want to give them fluids. We want them to be able, if they can drink, fantastic, take in some fluids, or if not, we can also give them some IV fluids. So we want to increase fluids. We're doing this because as we increase those fluids, we're hopefully going to be able to perfuse those kidneys, push that stone out. As we're pushing that stone out, it's really important for us to strain the urine, okay? Couple of reasons. We want to strain the urine. One, so that we know when the stone comes out, we physically see the stone, right? Stone has come out, there it is, I see it, okay? Two, we can take that stone then and send it off to the lab to analyze it, to figure out what stone it was, okay? Was it one of these that we talked about earlier? Is it something different? Because that is going to indicate to us what our patient's care should be further to prevent other stones just like it. So do we need to alter our diet? Do we need to change some medications? So we're going to strain all urine. and then hopefully send it to the lab. So we want to promote our patient to be able to get rid of and pass this stone. One of the biggest ways we can do that is to encourage ambulation. So we want our patients to be able to walk, if they can, to hopefully get that stone moving. And we want to get these patients comfortable. So within the NCLEX and within your patient-centered care, you want to start thinking about their comfort. One of their biggest complaints is pain. So we want to make sure we're taking care of pain. Two ways that we do it is we can give an NSAID first, particularly ketorolac or Toradol it's called. It's an NSAID that we can give through the IV, helps decrease that inflammation, helps the patient have a little more comfort. If they're having some trouble with NSAIDs, they can't have an NSAID, if it's not working for them, we can move into the opiates, and then we can give this patient morphine or some other medication depending on what the doctor orders. Once their pain is also under control, we can also work into those other symptoms or issues that they're having. If they're having some type of infection going on, we can give them the correct antibiotics to treat the infection. If they are having nausea and vomiting, right, maybe this is the first time they're getting opiates, so they are experiencing nausea and vomiting, we can give them an antiemetic. We can give them ondansetron, Zofran to help them. And then we can also give an alpha blocker. So alpha blockers such as tamsulosin or Flomax are those medications that help create the diameter of our ureter to dilate, creating a bigger passage for that stone to come through, okay, and then pass that stone. And then once we have figured out, got this patient comfortable, we're able to pass the stone, we're able to figure out what the stone was, we can then alter our diet, right? So depending on the type of stone with this patient, we may want to decrease proteins, we may want to decrease purines, we may want to increase something to decrease, and all has to do with what type of stone they have and what is going on with that patient. So that is one that is not particularly the same for every single patient, but the medications that we give, increasing those fluids, straining the urine, and getting them to ambulate are the biggest nursing interventions we want, along with documenting I's and O's and making sure that their vitals are stable. But these are the key components here for renal calculi or a kidney stone. So I hope this video made sense. I hope you learned something from it. If you did, hit that thumbs up, comment down below, and I'll see you next time.